So today we will study about antipsychotic drugs. In that we will study these are the drugs having a salutary therapeutic effect in psychosis. Psychosis means a disease in which these drugs have a therapeutic effect. First we will study classification of antipsychotic drugs. Antipsychotic drugs are classified into phenothiazines, buprenorphines, thiazanthine, or typical antipsychotics. These three are typical, and the last one is atypical. So in phenothiazines, there is chlorpromazine, triflupromazine, pyridazine, trifluperazine, fluphenazine. Next, in butyrophenones, it is haloperidol, trifluperidol, penfluridol. Thiazanthine, it is flupentazole. So first we studied phenothiazine, butyrophenones, thiazanthine. Phenothiazines, butyrophenol, thiazanthine. In phenothiazine, there are three types: aliphatic side chain, piperidine side chain, piperazine side chain. Aliphatic में two are there: CT, chlorpromazine, triflupromazine. What? Chlorpromazine, triflupromazine. Aliphatic, piperidine, piperazine. Aliphatic, piperidine, piperazine. In aliphatic, chlorpromazine, triflupromazine. In piperidine side chain, there is thiazidazine. Chlorpromazine, triflupromazine, thiazidazine. Next, in piperazine side chain, trifluperazine, fluphenazine. Trifluperazine, there it was triflupromazine, here trifluperazine, fluphenazine. And butyrophenones, in butyrophenones, haloperidol, trifluperidol, see triflu, triflupromazine, trifluperazine, trifluperidol, penfuridol, haloperidol, trifluperidol, penfuridol. So phenothiazine, butyrophenones. What we studied? Phenothiazines, butyrophenones, thiazanthine. In phenothiazines, aliphatic, piperidine, aliphatic में chlorpromazine, triflupromazine. piperidine साइड चेन में thiazidazine. piperazine साइड चेन में trifluperazine, fluphenazine. एंड इसमें haloperidol, trifluperidol, penfluridol and thiazanthine, flupenthiazole. Next, about typicals we will study first. Many more drugs have been marked in other countries but do not deserve special mention. Pharmacology of chlorpromazine is described as prototype, others only as they differ from it. Their comparative features are presented in table 3 to 32.1. Pharmacological actions of CP that is chlorpromazine, which is aliphatic side chain of phenothiazine. Pharmacological action CNS effect differ in normal and psychotic individuals. In non-psychotic individual, chlorpromazine produces indifference to surroundings, paucity of thought, psychomotor slowing, emotional quietening, reduction in initiative, and tendency to go off to sleep, from which the subject is easily arousable. Spontaneous movement are minimized, but slurring of speech, ataxia, or motor incoordination does not occur. This is most perceived to be unpleasant and has been referred to as the neuroleptic syndrome. The typical antipsychotic drugs have potent dopamine D2 receptor blocking property. and produce extrapyramidal motor side effects. They produce extrapyramidal motor side effects. As such, they are called neuroleptic drugs. They have neuroleptic syndrome. They are D2 receptor blocking agent. They produce extrapyramidal motor side effects. They are called neuroleptic drugs. Next, in this was in non-psychotic, and next in psychotic. In psychotic, chlorpromazine reduces irrational behavior, agitation and aggressiveness, and controls psychotic symptomatology. Psychotic symptomatology. Disturbed thought and behavior are gradually normalized. Anxiety is relieved. Hyperactivity, hallucination, and delusion are suppressed. All phenothiazines, what? All phenothiazines and thiazanthines and butyrophenones have the same antipsychotic efficacy, but potency differs. Efficacy is same, potency differs. In terms of equivalent doses, the aliphatic and piperidine side chains phenothiazines. Aliphatic and piperidine side chains phenothiazines, that is chlorpromazine, triflupromazine, thioronide, have low potency, produce more sedation, cause greater potentiation of hypnotics, opioids, etc. The sedative effect is produced promptly while antipsychotic effect takes weeks. So these drugs, that is chlorpromazine, triflupromazine, thioridazine, they are telling ki these drugs before producing antipsychotic they produce sedative effect. So they have low potency. Thus the two appear to be moreover tolerance develops. The sedative effect is produced promptly while antipsychotic effect takes weeks, in which chlorpromazine and tolerate develops to the sedative but not to antipsychotic effect. Thus, the two appear to be independent actions. Performance and intelligence are relatively unaffected, but vigilance is impaired. Extrapyramidal motor disturbance are intimately linked to antipsychotic effect but are more prominent in high potency compounds. So, in high potency compounds, extrapyramidal motor disturbance is seen and least in, and this disturbance is seen least in thioridazine, clozapine, and other atypical antileptics. Thioridazine, clozapine, and other atypical, in clozapine and other atypical, and in thioridazine extrapyramidal motor disturbance is seen least, and extrapyramidal motor disturbance is seen more in hypotensive compounds. A predominance of lower frequency waves occur in EEG, and arousal response is dampened. Lower frequency waves. However, no consistent effect on sleep and architecture have been noted. The disturbed sleep pattern in a psychotic is normalized. Chlorpromazine lowers seizure threshold and can precipitate fits in untreated epileptics. The piperazine side chain compounds, who are they? Thioridazine compounds have a lower propensity for this action. Temperature control is knocked off at a relatively higher doses, rendering the individual poikilothermic. Body temperature falls if surroundings are cold. Medullary, respiratory, and other vital centers are not affected, except at very high doses. It is very difficult to produce coma with overdose of these drugs. Phenothiazines, butyrophenones, etc. have potent anti-emetic action exerted through anti-emetic action. However, they are ineffective in motion sickness. And next, we will study mechanism of action. In mechanism of action, all antipsychotics except all antipsychotic except uh, clozapine, like atypical ones, have potent all antipsychotics. सारे एंटीसाइकोटिक ड्रग्स हैं उनमें क्या है पोटेंट डोपामिन D2 रिसेप्टर ब्लॉकिंग एक्शन डोपामिन रिसेप्टर को ब्लॉक करते हैं एंटीसाइकोटिक्स पोटेंसी हैव शोन गुड कोरिलेशन विद देयर कैपेसिटी टू बाइंड टू D2 रिसेप्टर phenothiazines and thiazanthines also block D1 D3 D4 receptors but there is no correlation of such blockage with their antipsychotic correlation blockage of dopaminergic projection to the temporal and prefrontal areas constituting limbic system and in mesocortical area probably responsible for antipsychotic action. Okay, blocking project temporal, prefrontal, mesocortical. This contention is strengthened by the observation that drugs which increase dopamine activity, that is amphetamine, levodopa, this induces or exacerbates schizophrenia. Moreover, the dopamine receptor population have been found to be greater in the brains of untreated psychotics. In untreated psychotics, dopamine receptor are greater, more, and higher dopamine levels have been detected in the nucleus. Higher dopamine levels, accumbens, caudate nucleus, and putamen of schizophrenics who are schizophrenia, who have increased dopamine activity. Levels have been detected. A dopamine hypothesis. What? Dopamine hypothesis of schizophrenia have been propounded emphasizing dopamine overactivity in limbic area to be responsible for the disorder. Accordingly, blockage of dopamine over limbic area produces the antipsychotic effect, while that in basal ganglia produces Parkinsonian adverse effect. The delayed onset of these effects may be explained by initial adaptive increase in firing of dopamine neurons and dopamine turnover, which gradually subsides in state of persistent inactivation as the drug is continued, corresponding to the emergence of the therapeutic effect as well as the extrapyramidal side effect. However, dopamine overactivity in the limbic area is not only abnormality in schizophrenia. Other monoaminergic, that is serotonin as well as amino acid glutamate neurotransmitter may in addition be affected. That LSD and other indole hallucinogens are 5-HT2 receptor agonist points to a role of brain serotonergic system is receptor agonist points to a role of brain serotonergic system in schizophrenia. It has been found that dopamine activity in prefrontal cortex is actually diminished in schizophrenia, but this has been corrected to the cognitive impairment and other negative symptoms. Only the positive symptom, hallucination, aggression, etc., appear to closely link to dopamine overactivity in mesolimbic area, but not negative symptoms of apathy. There is some evidence that hypofunction of neuromuscular dopamine glutamate receptor in the brain could also be contributing to schizophrenia. Notwithstanding the above reduction of dopaminergic neurotransmission, Notwithstanding the above, reduction of dopaminergic neurotransmitter is the major mechanism of antipsychotic action. The dopamine hypothesis fails to explain the antipsychotic activity of clozapine and other atypical, which have weak D2 blocking action. However, these drugs have significant 5-HT2 and alpha adrenergic blocking action, and some are relatively selective for D4 receptors. Thus, antipsychotic property may depend on specific profile of action of the drugs on several neurotransmitter receptors. Positron emission topography studies of T2 and other receptors occupancy in the brain of antipsychotic drug treated patients have strengthened this concept. Dopaminergic blockage in pituitary lactotropes causes hyperprolactinemia, while that in CTZ is responsible for antiemetic action. This was all in this was on mechanism of action. Now we will study. This was on CNS. Now we will study ANS. Neuroleptics have varying degrees of alpha-adrenergic blocking activity, which may be graded at CPZ triclopyrazine thioridazine equal alpha blocking, and they have greater than fluphenazine haloperidol trifluperazine. That is, more potent compounds have lesser alpha blocking activity. See, CPZ trifluperazine they have lesser potency, and now they are telling they have higher alpha blocking. Okay? More potent, less alpha blocking. Anticholinergic property is weak and may be graded as phenothiazines have weak H1 antihistaminic and anti-serotonin actions as well. Local anesthetic. This was on ANS. Next, local anesthetic. Chlorpromazine is a potent local anesthetic as procaine. However, it is not used for this purpose because of irritational action. Other antipsychotic drugs have weaker or no membrane stabilizing action. CVS. Neuroleptics produce hypotension by a central as well as peripheral action on sympathetic tone. The hypotensive action is more marked after parenteral administration and roughly parallels the alpha-adrenergic blocking potency. Hypotension is not prominent in psychotic patients but is attenuated by hypovolemia. Partial tolerance of the hypotensive action develops after chronic use. Reflex tachycardia accompanies hypotension. High doses of CPZ directly depresses the heart and produces EEG changes. High doses. CPZ exerts some anti-arrhythmic action, probably due to membrane stabilization. Arrhythmia may occur in overdose, especially in thioridazine. Okay. Next. Endocrine. Neuroleptics consistently increase prolactin release by blocking inhibitory action of dopamine. So, dopamine, what it does, dopamine blocks prolactin. So, if neuroleptic is blocking dopamine, then it cannot block prolactin, so its level increases. On pituitary lactotropes. Neuroleptics considerably increase prolactin release, and by blocking inhibitory action of dopamine on pituitary lactotropes, this may result in galactorrhea and gynecomastia because prolactin is increased. Secretion of pituitary hormones including GH, gonadotropins, ADH is reduced by CPZ, and ACTH response stress is subdued. However, clinically significant consequences is no. Though in general, antipsychotic drugs do not affect blood sugar level. Though in general, antipsychotic drugs do not affect blood sugar level, CPZ and few others have potential to impair glucose tolerance or aggravate diabetes, as well as elevate serum triglycerides. This often associated with weight gain, which may be causative factor along with attenuation of insulin resistance. Tolerance and dependence. Tolerance to the sedative and hypnotic actions develops within days or weeks, but maintenance doses for therapeutic effect in most psychotics remain fairly unchanged. Yes, despite increased dopamine turnover in the brain, the antipsychotic extrapyramidal and other action based on dopamine antagonism do not display tolerance. Neuroleptics and hedonically bland drugs lack reinforcing effect so that chronic recipients do not exhibit drug seeking behavior. Pharmacokinetics. Oral absorption of CPZ is somewhat unpredictable and bioavailability is low. More consistent effects will produce a IM or IV administration. It is highly bound to plasma as well as tissue proteins. Brain concentration is higher than plasma concentration. Volume of distribution large. Life it is metabolized in liver mainly by CYP2D6 the number of metabolites. The acute effects of a single dose of CPZ generally last for 6 to 8 hours. The elimination of T-half is variable, but mostly it is range of 18 to 30 hours. Effects 6 to 8 hours, elimination 8 to 30 hours. The drug accumulates on repeated administration and is responsible to give the total maintenance dose once a day. Some metabolites are active. Moreover, the duration of clinical benefit is much longer related to the elimination. Longer elimination, that's why it is benefit. Probably because of the tight binding to the D2 receptors, the metabolites are excreted in urine and bile for months after the discontinuing the drug. The broad features of pharmacokinetics of other neuroleptics, this we don't need to study. Okay, thank you guys.